Today we'll continue, and the idea is to talk a little bit about the right ventricle, because also in one of the next talks I want to start talking about athlete's heart and what's happening with sports. But before starting that, I think it's worthwhile to look at the right ventricle and look a little bit at the morphology and a couple of peculiarities of the right ventricle, which are important to know and then to look at further remodeling. Okay, so, well, as I said before, also, when you look at the right ventricle, so the shape of the right ventricle is very different from the left ventricle. So as we said before, when you take a left ventricle, and these are segmentations from MRI images. So left ventricle is kind of an ellipsoid in some ways, cut by the mitral valve and then going towards the aortic outflow tract. But the right ventricle is really kind of attached and more crescent moon in diameter or in cross section, and is attached to the left ventricle in such a way that the whole heart itself remains more or less kind of elliptical, so that it fits within the thorax, and also that it doesn't have to move as a whole while contracting. And what you also see is that, so the right ventricle, while in the left, the mitral valve and the aortic valve, they are actually very continuous, and they actually they have like what they call like fibrous continuity, so they're really attached to each other. You see here that the tricuspid valve and the pulmonary valve, they really are separated, and so the pulmonary valve is really having this kind of outflow tract, so that's already different in shape. But the main thing is that the whole shape is different, and so you see it here also. So you see this kind of these two inlet-outlet portions, and then when you go to the apical part, of course, it's like very pointed, because that's where it forms together the apex with the left ventricle. And so here you see on this MRI also, so you see the cross section of the right ventricle. You see that the right ventricle wall is, of course, much thinner than the left ventricle wall, because the right ventricle works at much lower pressures. And one thing you can also already see is when you look at the ring motion. So as we said before, so one component of contraction is that the ring moves towards the apex. You see that the right ventricular, so the tricuspid ring, is actually moving more than the mitral ring. So you see that really this longitudinal component is really important for the right ventricle. So if we look a little bit more in detail at the morphology, so you see this cross section that I said. So you have the apical part, you have the inlet component, the outlet component. Here you see this is the tricuspid valve. Maybe another time we come back to the tricuspid valve, but the tricuspid valve in itself has an enormously wide anatomical variability, because it's actually something that develops under low pressures. And so, I mean, it just needs to be able to close in some ways and do its function, but there's relatively little constraints for the rest. And also another thing, which is maybe also relevant and that we can come back later on, is the tricuspid ring. While when you take the mitral valve, the mitral ring is more or less fibrous throughout, roughly. But the tricuspid ring is only very, very small part which is fibrous, which is the part which is more in the middle here. And all the rest is actually very elastic. So really the size of the tricuspid valve can change during contraction, or can very easily adapt also under different situations. Then, so you see here the outflow tract. So really that's a tube going towards the pulmonary valve. So the pulmonary artery comes there. Here you see some leaflets of the pulmonary valve. One of the things that you see is, so here from the tricuspid valve, you see these chordae going to some kind of papillary muscles. So that's what you see here. So these kind of prevent that the valve would kind of flap back. So would prolapse when the pressure is high and the contraction is taking place. One of the things that you see immediately also when we look at the apical part is that this is very trabeculated. So it's really a spongy area with many, many trabeculations. And also some of these, some of these larger trabeculations here are also quite important, and they form then part of the septum. So here you look at the septum that is then dividing the left and the right ventricle. And here you see again, so the very thin wall. So the right ventricular free wall is almost as thin as the atrium. So because it does work under very low pressures. So here you see the same again. One of the things that you see here also is like when we look at these trabeculations, and you see it a little bit here on this view. One of the things that you see is there is this trabeculation, which is like going from the free wall to the septum, and you see that in everybody. That's what's called the moderator band. Here you see it also. So there is like one large trabeculation which goes from the septum to the free wall, and this has as function to kind of keep the structural integrity partially of this apical part, but also we come back to that when we talk about conduction abnormalities. There's a lot of Purkinje fibers in there, so that's also an important part for the activation of the right ventricle. Okay, so then when we look at the fiber orientation, and I showed you this already when we were talking about the left ventricle. So what you see is like in the left ventricle, what we said before, you have this change in direction of the orientation of the cells from the epicardial, so the outside layer, which is roughly going from the base towards the apex, so in a longitudinal direction. And then it changes gradually so that the mid-myocardial fibers of the left ventricle are actually circumferential. And then it continues to change so that the endocardial, so the inner part, is again longitudinal. So you have this continuous change. Now, when we look at the right ventricle, and you see it partially here also, but you see it also on this anatomical specimen, what you see actually is that you don't have this triple layer structure that much. What you see is that actually the outer fibers of the right ventricle are predominantly circumferential. So this extra longitudinal layer is extremely thin or almost non-existent. So it means that functionally what people say that it's bilayered, but of course it's not really bilayered. What happens is that, so the endocardial part is more or less longitudinal, and then it goes towards roughly circumferential. And so you will see that actually this longitudinal part that you see here, so the inner part, that's the most important, and that's also what we said before, that is doing this longitudinal contraction, and that's what I showed you on this initial image, that is dragging this tricuspid ring towards the apex. And here again, you see nicely all the trabeculation, so the right ventricle is very, very spongy, especially in the apical portion. And so because of this fiber orientation, so we have these two components, as I said before. So the main one, and you see that nicely here on the stacked image, so you see is the dragging of the tricuspid ring towards the apex, and then there's a little bit of the change in the circumference, but not so much. So really, right ventricle is predominantly longitudinal in deformation. One of the things that you see also is like, well, the septum, that's a little bit a question, and I'll come back to that in a minute also. It's like the septum is, of course, structurally also part of the right ventricle. When we look at the right ventricle, we take the free wall and the septum together, but the septum is, of course, shared with the left ventricle. And so we also see the septum as a left ventricular structure. So you really have to see, depending on what you want to look at, whether you take one or the other and how you combine it. So as I said before, so these trabeculations are very important. Here you see very nicely also, so this is looking into a left ventricle where you see the trabeculations, where the outflow tract is very smooth. So what you see in the left ventricle is that when you go the septal part towards the aorta, because the aortic valve is really on top of the septum, that part is smooth. But what you see is in the right ventricle, because the pulmonary artery is, or the outflow tract towards the pulmonary valve is really becoming a tube, you see that the right ventricle is actually trabeculated everywhere. So really the whole part of the right ventricle, except and really this outflow tract, is very trabeculated, and especially this apical part. So you see the moderator band, and you see a lot of these also false tendons. So these are all electrical interconnections in order to have the conduction really taking place very quickly. Here you see, like when you use a flattening, for example, you always will see this kind of moderator band. Now, keep in mind also the moderator band, although we call it a moderator band, is actually very often a bunch of trabeculations. So in some people it's relatively thin, in other ones it's relatively thick. Like here in this specimen, what you see is that it consists of like several trabeculations. So there's a lot of anatomical variability, but there's always this structure which you have there. And having this structure and the trabeculation of the right ventricle is also what makes you able to identify it as a morphological right ventricle. And I show you later on a couple of examples of systemic right ventricles where you clearly see that these are kind of distinct markers of the right ventricle. So I showed this before also, I'm not going to go much in detail, but what you can show is that these trabeculations are actually very helpful, because the trabeculations, they work as a sponge in some ways in the end, and they make that you can displace volume without having fully to deform your tissue. So what you do is, instead of that the tissue has to deform, you bring the tissue closer together. Of course, there's a little bit of deformation for that, but in total, you have to do much less deformation of tissue in order to do volume ejection. But of course, when we think about the structural integrity of the wall when it comes to pressure loading, for example, and even when we look at it in a way like using Laplace law, then we say that the thickness of the wall is, of course, needed in order to withstand the pressure. And so when you have sponginess, of course, that doesn't have structural integrity in order to look at pressure. So that means that you have this balance between amount of trabeculation and the thickness of the wall, and you balance volume efficiency versus the ability to withstand pressure. So here is one of these examples of a systemic right ventricle. So this is actually an adult patient with a systemic right ventricle. And what you see here is that this right ventricle is huge, and you recognize it by these trabeculations and the moderator band. And here in this case also, the left ventricle, or the morphological left ventricle, which is connected to the lungs. So that's what we call the subpulmonary ventricle. What you see here is that it's being compressed in some ways, but then also what you see is that the shape of the right ventricle is actually really determined by its function in some way rather than structurally. Because what you see here is that the shape of the left ventricle that works under low pressure with a high pressure right ventricle, then the left ventricle becomes a little bit this kind of more crescent moon shape and hugging the systemic right ventricle. Now, what is interesting here also in these patients, and I show you a couple of examples later on also, is that when this right ventricle is systemic and works under high pressure, so that means that, of course, high pressures lead to high wall stresses, and myocytes that feel high wall stresses, as we said before when we talked about pressure loading, will become hypertrophic. So tissue is becoming thicker, is becoming hypertrophic as a response to increased pressure. But of course, what you see here is this hypertrophy of the trabeculations. While hypertrophy is good because it gives you more contractile material in order to develop pressure, what you see here is that actually this hypertrophied trabeculations are actually filling the cavity. So the whole apex is actually full of these hypertrophied trabeculations, where even if the cells there are normal and the tissue would be able to contract normal, what you see is that there is no volume, there's no fluid in there that can eject it. So what happens there is that this is a bunch of tissue that maybe can help in developing pressure, but it will not contribute to the output at all. So that means that here about half of your volume of your cavity here is actually not useful, while there is a lot of tissue. And what you then see is that because of this, of course, in order to be able to generate the stroke volume, what you will see, as we talked about volume loading, so in order to, with less tissue or less deformation, being able to generate the right amount of stroke volume, you need to dilate. And you see this kind of dilatation of the base predominantly in order to still have enough volume inside in order to do the ejection. So the question is then a little bit here also, how do you measure this, or how do you interpret this? While probably if you measure this volume, it would be almost the same as the volume of a normal ventricle, while it's clear that this ventricle is dilated. So the question is then, again, and this is something that people that do segmentations also always have, is like, do you take these trabeculations in the cavity or out of the cavity, or do you separately describe them? And unfortunately, also, while you see them relatively nicely here on this MRI, it's extremely difficult to really segment them because of the resolution, and of course also because of the constant motion. So they're a little bit blurred and at the edge of the resolution that we can see. Now, another interesting, well, something that I find interesting but hasn't been described or studied in a lot of detail is actually also this trabeculation. So it seems when you start looking at right ventricles, you always find this trabeculation, which goes from the tricuspid, the tricuspid, or in this case, of course, the mitral ring, because this is a mitral valve. Remember that this is a systemic right ventricle. So that goes from the ring of the valve and then attaches kind of, well, when you look at the overall length, so about maybe 1/3, 1/4 of the overall wall length. And what you see here is that in this case, so you get dilatation of the right ventricle, but you get this kind of pouching in some ways. So this part here gives some structural integrity. And so you see here this very typical shape change that you see in many of dilated or failing right ventricles. Okay, here are some other examples also to show you, because one of the things with the systemic right ventricle is the problem is that, as you see in the previous patient, that's like failing right ventricle. What you see is that as kids, this is quite okay to have a systemic right ventricle. It's not much of a problem. But by the time these patients get like 40 years old or something like that, you start to get this dilatation, this hypertrabeculation and things like that. And then they start to fail. So the problem is then the only thing that you can do is then, of course, well, first heart failure management, and if that doesn't work, do a transplantation, of course. So while in principle, I mean, theoretically, the right ventricle can adapt physiologically to these pressures. The only thing is that then later on, the further adaptation is a bit of a problem. The other discussion is also whether, of course, the fiber orientation will be different. But we don't know how the fiber orientation would be affected, or whether there would be kind of some increase in some of these fibers when it becomes systemic or not. So these are things that we still have to investigate further, for example, with the synchrotron imaging. And this is an example of a child with what they call congenitally corrected transposition of the great arteries. So that means that the only thing that happened here is that the right and the left ventricle were switched. But this is a normal circulation in brackets with kind of two serial components, because what you have is, if you only have a transposition of the great arteries, what that means, a pure transposition, what would happen is that the aorta and the pulmonary artery are switched, but the inflow and the two inflows, so mitral and tricuspid, are not switched. So that means that you actually have two parallel circulations, one pulmonary circulation and one systemic circulation, which is only viable in fetal life because you have a connection between the aorta and the pulmonary artery, namely the ductus arteriosus. But we'll come back to that at another point. But the congenitally corrected, what happened there is that everything is, well, that both the atria and the vessel and the large vessel is switched. So that means actually effectively that you just switch the right and the left ventricle morphologically. And you can see that here already in this first image. So that's the earliest image. So you see again, you recognize this as a right ventricle every time because of this trabeculations. So that means that it's morphologically a right ventricle. And you clearly see that this is a right ventricle under high pressure because the cross section here is clearly spherical. So it becomes this kind of an elliptical area. So this is a systemic right ventricle. And now you see how over a couple of years, this is actually remodeling already. So even already in young kids, what you see is you start to get a little bit more of this hypertrabeculation in the apex, and you start to see that the base here is already starting to change its shape, and that this, even when you would look at the displacement there and you would measure it, that this would be changing. And the other thing, I'll show you some other examples, is of course the dynamics of the septum here can also be quite interesting. One of the things that you also see is with high pressure right ventricles is that overall, the right ventricle now is apex forming, as they say. So when you take the apex of the heart, so the point of the heart is actually the apex of the right ventricle. Well, if you remember, in a normal heart, the apex would be the apex of the left ventricle, and then the right ventricle kind of attaches to it. So looking at which of the ventricles is apex forming is actually also quite interesting and tells you something, of course, about the pressures that these are working on. So here you see a couple of other examples, and these are actually examples where you additionally start to get an aortic stenosis. So that means that also these right ventricles, these systemic right ventricles, are starting to work under higher pressures. But we're not going to look at that now, but the main thing is to look at the types of remodeling in some way. So you see here clearly that these profiles of trabeculations are very different. So this one, for example, you see has a very, very thin moderator band. Here it's much, much more. So you see here clearly that this, and you see that actually on the deformation, this apex is contributing still a reasonable amount. And here you see another one. You see also like the hypertrophy of everything. And yes, you see this apical hypertrophy. And this one, what you see here is you see that this is really like a failing right ventricle almost. You see there's no longitudinal displacement anymore. The only displacement now is a little bit, you see here this apex, but this apex now can contribute because it's so much dilated as a whole that it can still do some things. So that is because you had then the double problem of being a systemic right ventricle, which is then additionally pressure loaded on top of it. So you see the whole, this is what you get then when you look at the whole spectrum. So first, what you start to get is when it works under systemic pressures, you start to get this hypertrabeculation in the apex, dilating of the base. And if then you still have a lot more problems, then you can get an overall dilatation of the whole ventricle. And that's what you start to see here, of course, in this example. And you see also the different ways that the left ventricle, for example, can contract. And what you see here is that here, the left ventricular contraction is predominantly radial, which is also quite interesting. So there's a bit, well, probably if you measure it, this looks like a reasonable amount. But here you see that the left ventricle, because left ventricle has a lot of circumferential fibers, you see that it contracts differently in this case. So here is another echo example. So you see again the different types of trabeculations. And here you see already also that there's so much dilatation here that you see that this mitral valve is like being tented in some ways. So it's really that the papillary muscles that it's connected to are kind of displaced and the valve cannot close anymore. So very often on top of that, you would have then some mitral regurgitation, then would lead to additional volume overload, which again would lead to, as we said before, the dilatation, and which then will contribute to the failure. Now, if you look at this one, it's actually quite interesting. So although what you see is this apical part is indeed hypertrabeculated, but here you see that this apical part, especially also from the left side, is actually contracting very weirdly in some ways, and it's actually even being pushed out here in some ways instead of fully contracted. And you see here also the role of this moderator band. So the moderator band really helps in order to keep the structure there of this right ventricle. The question is whether this is advantageous, of course, in a systemic right ventricle. Probably not, but if you have it, I mean, it will take part of the dynamics. So that means, for example, also when you want to analyze function here, even analyzing strain, or even if you would want to make a computational model, putting these things in is very, very important. So modeling a right ventricle, I mean, if you have simple kind of anatomy, then that's fine. But as soon as there's a little bit of remodeling, or as soon as you have this pressure loading, you have to keep in mind that the structure of the right ventricle is very, very different. And you have to take into account this, what we said before, so the whole apical trabeculations, and then this kind of pouching also that you see much, much less in a left ventricle, but more in the right ventricle because of these trabeculations that will keep it there also. Here you see some others. So here you nicely see again this large trabeculation here. So here, so the shape of the right ventricle, and you see that actually the wall, instead of going smoothly, so a left ventricle will always have a smooth curvature. What you will get is you get this angle in here because of the connection of this right ventricle. And so the question is now, of course, also is like, how is this kind of dilatation taking place? So is it the whole wall that dilates evenly, or is it only this part of the wall that has been dilating, or is it the apical part? So that's actually quite tricky in order to do. And the only way to do that during longitudinal follow-up is also if you have these trabeculations there. With a good MRI, you might be able to see it. Probably with a good CT, you are able to see it. With echo, using these trabeculations as landmarks is quite tricky in some ways, so it's not so evident. And again, you see here kind of different types of these, the variability in this kind of apical trabeculations. One of the things that you also see in this case, you see this kind of this post-systolic motion of the apex. So which is related of the combination that there is this large pressure loading. What we said before is that normally in the left ventricle, when you have pressure loading, when you have hypertension, you expect the post-systolic to be in the base of the septum. What you see here actually has to do much more with the activation. So what you see is that the apical part is contracting earlier compared to the base because of the way the right ventricle is activated, but we will discuss that when we talk about cardiac resynchronization therapy. So again, you see that if you start doing measurements here of shape, of deformation, of volume changes, there is nothing which is straightforward. So which is the volumes to take? How do you divide the wall into different segments in order to compare it to normality? What do you do with this apex and the volumes inside? So what do you do then with this kind of trabeculation, which seems to be structurally important? So that makes that evaluating these hearts is actually quite difficult, at least from the anatomical point of view in some ways. So it's maybe easier in some ways to look here at Doppler profiles, so at the dynamics, the temporal dynamics of the outflow and the inflows, in order to say something or do some follow-up in some ways. Now, let's come back for a moment to the septum. When you look at it, it's actually quite interesting, is that at the moment that the resolution of ultrasound machines started to become good enough, what you started to see is that you would always recognize this kind of white line in the middle of the septum. And so it looks like the septum is a bilayered structure in some ways. And here, if you look at it, when you look at the thickness, for example, you see that it's roughly in the middle and diastole, but you see in systole, you clearly see that the left ventricular side, which is here, is about double the size than the right ventricular side. So the left ventricular side is thickening a lot more than the left. So the left ventricular is thickening much more than the right ventricular side, which again also tells us something about this kind of longitudinal versus radial component in some ways. Here you see a patient with amyloidosis, so where you have like deposition of some kind of starch-like things within the cells, and these get very hypertrophic hearts, so very thick hearts. Also, you will see that they have much less longitudinal motion, and then they're really much more like a radial pump. But it's just to show you that you very nicely see this kind of layer in the middle. On ultrasound, you see it because it actually is I'll show you in a minute, is a change, a relatively sudden change in fiber directions, which for the ultrasound makes a kind of nice reflector. Even if anatomically this can be extremely thin, so it's not that you have like a layer in there, but you have a change in the structure. And that's what you see here. So you see that actually in the mid-septum, there's a relatively sudden change in directions. One of the things that you also see is that here you see this kind of white lines, which are actually related also to vasculature. What you see is when you look at some synchrotron images, you see that there in this mid layer, you have the change in fibers, but you also have a lot of vasculature there exactly located. So now, one of the things that you can start seeing is like, okay, how does this influence pathology? Let maybe come back to this image. Also to show you when you do deformation analysis, one of the things that you see is when you look at longitudinal deformation. So some people are trying to do kind of multi-layer strain analysis because the software used for strain allows it. But what you clearly see here is that, of course, in the longitudinal direction, the tissue is fully connected. So that means that you cannot have really differential changes or differential longitudinal deformation unless there's a bit of shearing, which there would be. So there would be a little bit of shearing of the right versus the left ventricular endocardium, but that is minimal. So what you can say is that the longitudinal component of the left and the right side are very similar. But of course, looking at the radial component and or the circumferential component, you see that that can be totally different because they can contract or they can deform independently. Now, unfortunately, when we use speckle tracking, for example, it's extremely difficult to look at these differences. But we can look at these differences, for example, with M-mode, or if we would do kind of tissue Doppler in kind of a radial direction. Now, to also show you what the consequences of this is in some of the pathologies, like here you see, for example, two patients. These are two different patients with infarcts of the septum. And so here you see there's an apical infarct here in the left ventricle, and you see that the right ventricular side is actually fully protected and is not infarcted. And here you see that the left ventricular part is from a very sudden place. You see that you get that there's no tissue anymore. So this is the infarcted area, and this is actually becomes hypertrophic as compensation in some ways. And here you see one with a full kind of septal infarct. And one of the things that you see is, so the left side is kind of totally gone, but you still see that there's a bit of a right side. So that means also when you look at the perfusion of these areas, that they actually have distinct vessels that would perfuse it, and that you can get this kind of differential infarcts, for example. So this shows you again that in the radial direction, so they can be seen as functionally independent components almost. You see here of an M-mode of this patient actually. So you see the very bright line, which is the infarct area, but you see the preserved right ventricular side. And this is not what we showed you when we're talking about coronary artery disease, that this is like a subendocardial infarction. No, this is in the septum, differentially left and right infarctions. Of course, what you see now is that this, although there is still a right ventricular myocardium, of course, that myocardium is neither thick enough nor has the ability to deform the septum, because of course, because of the scar, you will see that that can't happen. And what you see here actually also is that because the apical part contracts, it will actually be dragging this kind of infarcted left side there. And you see this kind of a little bit like apical kind of rocking motion in some ways because of this kind of preserved contraction there. So it has as an advantage that you still have structural integrity as a whole of the septum, because what you see sometimes, if patients have a huge infarct in the septum, for example, that you could get rupture of the septum. And so you get what's called an ventricular septal defect because of this. But in reality, you don't see it that often, and that is mostly because very often then the right side is protected and is still there and then provides some integrity, not enough to contribute a huge amount to the deformation and the ejection, but still enough to leave it somehow structurally intact. So here you see an example of, in this case, right ventricular hypertrophy. And what you see now is that the thickness of the both layers are more or less the same. So you see here also during contraction, you see here that the mid layer is that this layer is now really in the middle, and that the left and the right side are more or less the same. So you see thickening at the right side while there's no hypertrophy at the left side. So you can see that there's differential hypertrophy also there. So it might be interesting to describe that, but as I said before, it's relatively, you need good echo windows, and you need to specifically look at this. So this is not something that people would generally report currently in clinical practice. But again, if you want to do a detailed structural analysis of either the left or the right ventricle, especially with the septum, keep in mind it's a shared structure where probably the longitudinal deformation would also be shared and more or less the same, but the radial/circumferential deformation, not necessarily. And it can be different, and it can show different adaptations also. Now, this is something that I showed you before also, but I want to come back to that also again, is that when we look at the right ventricular structure, as we said before, so structural integrity is done by everything, including the pericardium, so the sac which is around the right ventricle. Because here you see this example of patients before and after surgery. So you see here with the pericardium closed and here with the pericardium open. And when the pericardium opens, you see immediately this bulging of the right ventricle so that it becomes more spherical in diameter. So even working at low pressure, because it's such a thin wall, if you don't have the pericardium which holds it together, you will see that it immediately bulges there. And you see here again that it's actually here the moderator band which keeps the apex still more or less in structure. So you see here really that it's not the whole wall which is bulging, but it's the wall which is kind of between the tricuspid valve and the moderator band, and the apex itself remains in some way the same. And you see that that actually also changes. So you see it here nicely in the cross section, so that it becomes more spherical in some ways. And by this angle change that you get there, and this change here also in this geometry, what you see is that actually the deformation of the right ventricle and the displacement of the ring, that is changing. You see here when you measure the displacement of the ring, it looks like it's changing. This is not because the contractility or the tissue is different, but it's really because the whole geometry is different, and thus the orientation of the myocytes with regard to the pressure, so where the endocardium changes shape, and then you see that that influences the amount of deformation that you will see in one component or the other. So here again, it's important to keep in mind that you don't have only the left ventricle or only the right ventricle. As I said, you need to look at the septum also, but you also need to keep in mind there's the pericardium that will give some kind of structural integrity. Now, mostly when we look at remodeled heart, the pericardium would, if you have a dilated heart, it would grow and the pericardial shape would not dramatically change. Although there's not, as far as I know, not a huge amount of research, whether you look at the whole heart geometry, but I think it's not changing so dramatically. It's mainly the internal changes that become important. And just like to kind of finish up also, it's like here is some other examples. So what I said before is like, so the right ventricular structure and geometry and shape depends on its conditions. So normally it's this kind of crescent moon that is attached to the left ventricle. But if it either becomes pressure loaded as a systemic right ventricle, you start to see all these changes in shape, of course, just because of the pressure loading, but then later on because of the differential hypertrophy and some trabeculations, including the moderator band, and also this basal trabeculation that kind of keep the shape in some ways. But what also happens is, of course, that if during development we have changes in conditions, what you then see is that, of course, the right ventricle can also look differently. And we're not going to go in detail now here, but here are just 3 different fetuses with different conditions where you see that there's changes in the heart. And this you have, for example, intrauterine growth restriction, which means a too small placenta, which would be like a higher resistance. So this is a pressure-loaded fetal heart. And you see that the heart becomes almost spherical instead of more ellipsoid with biventricular changes in sphericity. Now, if you have an IVF baby, for example, so with assisted reproductive technologies, what we see regularly is that the right ventricle actually becomes more spherical, while the left ventricle remains the same. It's not completely clear yet why that would be, but this is something that you observe. Or when the mother has diabetes, for example, what you then often see is, for example, you can see like a thicker wall also with some changes in the sphericity. So you see that when we look at the right ventricle and any component, whether it's structure or deformation or something like that, we have to keep these things in mind that we have to interpret it together. It's like, what are the conditions that lead to this? What are the conditions under which it works? And how did this ventricle develop from the first place? All of these things might be different. So that makes that the right ventricle actually is much more complex in some ways than the left ventricle, which is then, as I said before, it's structurally different. It has a different fiber structure, although we don't know too much how the fiber structure would change later on under changing conditions, whether there's a differential hypertrophy of certain longitudinal or circumferential or something like that. We don't know that, so that is still caveat. But it means that all of these different things are different. And so, as I said before, we have to combine it, we have to understand it. And by doing that, we can try to evaluate right ventricles and especially do follow-up, for example, of right ventricles.